the page. This allows me to keep track of any of your questions and get answers from our lovely panelists. For anything else, please use the chat function. You can discuss the session, share useful links or email addresses, but just make sure that everybody is able to see that. If you are not comfortable having your name out in the public, please feel free to change it. You can see how to do this at the bottom of the screen. Also, just be aware that as we are on Zoom and people are in their homes and different spaces, we may have visitors such as cats and dogs and unwanted noises in the background. Please bear with us in these instances. I would also like to take this opportunity to thank our sponsors who have made the Fast Tracking Scotland Summit possible, and to make you aware they have not endorsed, supported or paid any of the speakers, nor have they influenced any of the content of the sessions. So what is involvement? Involvement is the comprehensive participation of people living with HIV to help drive forward meaningful and positive change in education, treatment, services, and policy decisions. We consider meaningful involvement when the thoughts and opinions of people living with HIV are incorporated into the design and the delivery of services. However, involvement should not be tokenistic. Input has to be included in all decisions that are moving forward when we're working with HIV services. For HIV Scotland, we run the Community Advisory Network to allow people living with HIV to come together to share their experiences, thoughts, and ideas with us. We take this involvement and use it to influence all of the work that we do. Furthermore, we also take these ideas and use it to implement changes in policy, as well as support people that provide services for those living with HIV. The Fast Tracking Cities initiative is driven by involvement of people living with HIV. And to tell you a little bit more about what Fast Track Cities is and why it is important to people living with HIV, I'm going to hand over to Bertrand to tell you a little bit more.
Thank you very much. Can you hear me?
Yeah.
Okay, so thank you very much for inviting me to talk on that specific topic that is, as you said, really at the center of what the initiative is about. And to just show you what we at IAPAC envision as the involvement of people living with HIV in Fast Track Cities, I just want to share a few examples of the way it has developed or is developing in specific Fast Track Cities on the continent. And basically, the main point I want to make, one of the main points I want to make, is that in many places, in many Fast Track Cities, there are no specific organization of people living with HIV, and making sure that people living with HIV are involved in the initiative has to go through the sort of bias of involving different communities that are affected by HIV. But at the same time, it also speaks to the fact that communities are transsectional, that very often you're not only part of one single community, and you know, you can be MSM and using drugs and living with HIV and a migrant and many different things, and basically we're all part of different communities. So the main point for us is making sure that in everything that Fast Track Cities develop, the different communities involved in it include people living with HIV. And I have a few examples to share with you on the next slide. Next. Again, sorry, that's, yeah, two more, please. Voila. So that's a few examples of what has been developed in fast-track cities in Europe this year. Keeping in mind that, as Heather just said, we've all been also impacted by COVID-19 this year. And the communities that have been involved and are involved in developing fast-track cities programs have also been faced with these new challenges. But I wanted to talk very quickly about a few of these examples. The first one is Berlin. If we can see it again. Yeah.
Sorry, I'm having a little bit of a slow internet on this side.
That makes me feel a lot better because usually that's me. So, Berlin, where a checkpoint opened just a few months ago, that was actually designed by clinicians and the Berlin local government at the beginning, but when they worked on designing the kind of services that the checkpoint should offer, including opening hours, communications on the services available at the checkpoint, link between prevention and care and treatment, very quickly communities got involved in the design of the whole project, including MSM and migrant communities. And the interesting thing from the first few weeks after the checkpoint opened was that 75% of the people using their services were migrants, a majority of them from Syria, and 75% of these same clients, can you go back? Of these same clients were MSM, which actually means that about half of the people who, 82. Half of the people who used the services of the checkpoint were at the same time migrants from Syria and MSM. And about 1/2 of them, so 25% of the people using their services, were people living with HIV. Again, talking about cross-sectionality of communities. It is the first and only place so far in Berlin where everyone, including undocumented migrants, have access to free of charge ARVs. That doesn't exist anywhere else in Berlin or in Germany for that. In Brussels, when they went into lockdown, which was back in April, and then they've been on and off lockdown a few times since then, the first thing that the communities of people living with HIV did was negotiating with the municipality, the mayor's office and the health department, so that ARVs would be available from all city pharmacies, which was not the case before that. You had to go to a hospital pharmacy to get a prescription for ARVs, and there were only 3 pharmacies doing that. When national lockdown came into place in Brussels, that's one of the first changes that happened, and it happened thanks to the commitment and the push from the communities of people living with HIV. Now the main issue and the main priority in Brussels is to make it permanent, make it sure that people living with HIV can still have access to ARVs from city pharmacies even after lockdown is lifted for the whole city. In Prague became a fast-track city 1 year ago. It's an interesting case where actually 19 different community organizations were involved in designing the strategy and the action plan for Prague as a fast-track city. The first thing they wanted to do was opening a checkpoint and renewing campaigns against stigma and discrimination with 2 priorities. One was advocating for PrEP and sharing information on PrEP. And the second one was sharing information on U equals U. They did that in the middle of the COVID-19 crisis last August. The opening of the checkpoint has had to be postponed to 2021. But again, it involved all the communities that are affected by HIV, including 2 organizations of people living with HIV. I want to say a few words about the program in Montpellier on the peer-to-peer harm reduction program that is very innovative at the national level in France. That's the first program where people who use drugs recruit other people who use drugs to become part of a harm reduction program. And that does include people who use chemsex. And that's the first time that is being done in France. And again, if you look at the communities and people who do implement both these programs, a number of them are people living with HIV involved in different communities. So I don't have time to go over all the examples I had planned on talking about, but my point is really to say that if we want to really make a difference, we need to make sure that people living with HIV are involved as one of the communities, but also are involved in all the communities that we work with and all the plans that we want to design to implement innovative programs. And I'll stop there.
Thank you so much for that, Bertrand. I know there is so much that you have the opportunity to say, and there is many examples of fantastic things that have been happening that we do obviously want to share. We have limited time for each session, and you've done so much work that it's amazing to have you here with us, and thank you so much for sharing that with us. Just now we are going to move on to Colin Stewart, who's part of our Positive Voice Grampian, and he is going to talk about being involved in the Fast Track Cities initiative. And Colin, I believe that you're sharing your own slides.
Yes, if you could stop sharing, then I can start.
Yeah.
Oh. And there we go. Okay, so thank you, everyone. So I'm Colin Stewart, and I've been asked to talk about involvement. So how did Aberdeen become a fast track city? Well, our Positive Voice, HIV Scotland was instrumental in getting our Positive Voice started. And once we were up and running and working as our own entity, we continued to work closely with HIV Scotland. While we were working on our developing our strategy and action plan, looking at what areas we needed to be working on and the priorities, we were getting data from the NHS regarding Aberdeen and Grampian's demographics. And there was a high prevalence in late diagnosis and diagnosis of heterosexual men over 40, and also with oil business workers. After a meeting with HIV Scotland, we started looking at fast track cities and realised this was something we needed to be involved in. But how? Our initial action plan focused on what we needed to do locally to combat some of these issues that we were finding, and we identified some of our partners that we would be working with. In March 2018, I attended a meeting with one of my housing committees regarding health, social care and housing at Marshall College, hosted by Jane Boyle, the Senior Wellbeing Coordinator for Public Health and Wellbeing. After a couple of comments I made at the meeting, Jane asked if we could have a chat afterwards and see if she could help. So after we had a conversation, we arranged for a meeting with our Positive Voice, and we met up with Jane. This meeting opened up doors for us to make the required contacts. For example, Sandra McLeod, Chief Officer of the Integrated Joint Board and Chief Officer at Aberdeen City Health and Social Care Partnership. After that meeting, we had Jane Boyle and Kevin Toshty, who was the Planning and Development Manager for Public Health and Wellbeing, attending our Positive Voice meeting. In February 2019, we actually met Sandra McLeod and discussed Fast Track Cities, amongst other things, and to raise awareness of what we do and what we wanted to achieve. She was very impressed at what we knew, what we had done, and what we wanted to achieve for people living with HIV in Grampian. This for us was a real turning point, and things started to fall into place. Sandra put us in touch with Councillor Sarah Duncan and various others within the Aberdeen City Health and Social Care Partnership who could help towards our aims. And Councillor Duncan was a really good contact, because the Fast Track Cities was something that she was very passionate about and wanted to get passed through council. So Sandra McLeod and our Positive Voice attended the National Fast Track Cities event in Glasgow, held by HIV Scotland. That's the first time I met Bertrand. After that meeting, we came back to Aberdeen and had a meeting with Sandra McLeod and Councillor Duncan, and had a discussion about Fast Track Cities. We then formed a Fast Track Cities working group, and we started working on the first draft of the High Level Action Plan. In August 2019, we sent through, it's not the final, it's a working document, it's constantly evolving, but the draft was sent through to Aberdeen City Council, along with the Fast Track Cities overview that we had put together for them to have a look at. In September 2019, Aberdeen City Council agreed unanimously to agree to the Fast Track Cities initiative, making Aberdeen the second city to agree and be signed up. It took a bit of time between the council agreeing and us getting it signed, but that was because we had a general election in the middle of it. Finally, in February 2020, the declaration was signed by the Lord Provost. Aberdeen Fast Track Cities Working Group were meeting every 6 weeks until lockdown hit in March. We started meeting online using Teams from April and continue to work on our action plan. Being the third sector organisation involved with Aberdeen Fast Track City and having been instrumental in getting Aberdeen to this moment has been a huge achievement for our Positive Voice, but there is still a lot of work to be done. The attitude survey results by Mark Diffie that was shown earlier shows the lack of knowledge around HIV out there, and or the lot of miscomprehensions that still exist. And it makes a strong case for the work that we are all doing in trying to end the transmissions. But that will only happen by passing on the knowledge, not the virus. One of the things I've always been saying, and people say, "Oh, Colin, you're always harping on about it," but we need a public information campaign to get the knowledge out there about U equals U, and get rid of that image that everyone has from that public commercial back in the 80s, 90s. So it's the working together, the involvement that has got us where we are, and it's been a fantastic few months for us with getting Fast Track Cities up and running. Thank you.
Thank you very much for that, Colin. Hearing what you've done within the Fast Track Cities initiative is absolutely amazing. Obviously, there's been a lot of work done in Grampian and in Aberdeen, so it's really great to hear. I am going to pass over now to Dr. Nicoletta Polacek, who is the chair for HIV Scotland, and she is going to talk to you about the importance of being involved. Oh, sorry. I'll get to your slides just now, Nicoletta.
Okay. Okay, next slide. Next again. Okay, thank you very much. I think that I'm going to talk about the importance of being involved, but the way in which I want to locate my presentation is very much against opportunities yet again to have the HIV space, as I define it, colonized. And in this way, I'm kind of challenging dominant discourses, which I believe reiterate the notion of permission to be heard, which is translated into permission to be involved. So I'm going to approach my talk on the importance of getting involved in the design and delivery of services from the perspective of someone who is living with HIV. And I wish to talk about involvement when planning the health and social care of individuals living with HIV and at risk of HIV, albeit the understanding that needs are very different. And if you can move to the next slide, please. I want to kind of clarify what I mean by involvement. I see involvement through collaboration, and by collaboration, I mean not only of different very powerful stakeholders in a sort of drop-down model, but I intend collaboration with different very disenfranchised communities living with and affected by HIV. I also see involvement through transparency of aims, objectives, intents, where power imbalances are at least acknowledged. And also I see involvement through social memory. And I mean social memory, I mean by social memory, the acknowledgement that communities most affected by HIV have the right, and I want to kind of stress this, to have their stories heard, and their stories need to be validated. If we can move to the next slide, please. So I'm addressing involvement very briefly, talking about drivers, benefits, and challenges. We can move already to the next slide, please. So kind of drivers are very straightforward to understand within the context of this conference, working toward the goal of 1990, which I don't need to explain to the audience, zero HIV-related deaths. And most importantly, from my perspective, zero HIV-related stigma, although all these drivers are very much interconnected and interrelated. And the process by which individuals living with HIV, I think, take part and influence their own healthcare and wider service provision, I think can be described and has been described in so many different ways. There has been so many different terms, and those who have had the opportunity to listen to some of my talks in the past, I'm very pedantic about the language and the key concept that is used around involvement. And I think that the concept of involvement is always embedded within concepts which are kind of vague and poorly defined. So, for instance, one thing is that academically speaking, some scholars identify involvement as involvement in decision-making and having sort of active participation in a range of activities. Those activities could be planning, evaluation, care, research, training, and recruitment, starting from what is normally defined as the expertise by experience of the person in collaboration with and as equal partners of professionals. Other academics, other scholars kind of move around concept of participation and involvement, define the terms as taking part in some sort of decision-making. But I think very much that what we need to distinguish at the outset is between aspects of involvement, which I would name as consultative processes, whereby people living with HIV have no control and activities are initiated by others, led and managed by professionals, and some sort of participatory processes where here I mean sort of collaboration with health and social care providers and some sort of share of power. But again, I'll go back to what I mean by share of power in a minute. When I think about conceptual frameworks of involvement, I think that immediately my reference goes to a sort of ladder participation, which represents involvement based on the concept that involvement is a sort of categorical term of power, with the ladder being a sort of guide to seeing who has power when important decisions are being made. And this model, I believe, hinders very much involvement because very seldom communities most affected by HIV have agency and consequently power. In fact, most communities affected by HIV don't even have access to a ladder. And it can be said, however, that this sort of linearity which goes with the model, the metaphor of the ladder, suggests that relationships are always very static and very much hierarchical. And I want to very much challenge this. So the degree of collaboration that I'm kind of proposing and I'm much more in favor of is the degree of collaboration, consequently involvement, which talks or think about a sort of spokes of a wheel with no form of involvement identified as superior to another. And the nature of involvement, I understand, and I don't need to share with anyone this because we're all very aware of that, is very complex. And there are different models of understanding involvement. But I still very much think that there should be no limit to the involvement of people living with HIV, and those involved are to be empowered adequately to be able to fully participate. But let's see in much more details what I think about the key benefits of involvement. If I can have the next slide, please. The benefit of involvement, to me, are very much around deleting or the possibilities whereby we can delete the notion of the ideal victim, and I will go back to that in a second. But also it's about attempts to dismantle hierarchies, which I have mentioned already, and tackling the experience of being invisible and voiceless, which is an experience that many communities can share. If we can move to the next slide, please. Its benefits, there are many challenges, and these are the key challenges I have identified when I'm thinking about involvement. Moving into social spaces where stigma is the dominant discourse is often very scary and is a very lonely place. Having to become the right fit for participation could neglect sense of self-worth for communities and for individuals. And repositioning, and consequently repositioning from patient to person is often very tiring, but is also a kind of lifetime project. Has to be, or we have to be on the go all the time to reposition ourselves. And repositioning is also, as I said, incredibly tiring and disempowering most of the time. Which goes with the next challenge, which is strengthening alternative identity stories could divide communities. One identity is better than the other, much more powerful sort of story. And finally, strategies of resisting dominant narratives around HIV subjectivity and also consequently societal views could potentially create, again, clusters of isolation when some voices shout the loudest. If we can move to the next slide, please. I want to kind of start to conclude my talk by saying that involvement is not politically unbiased. It is important to situate involvement within its sort of ideological and political relations to consider potential competing interests of those involved, particularly between key stakeholders, governments, research institutions, but also the third sector, and those accessing and working within different services. In other words, what I'm saying here is that there is a big difference between being invited to a party, co-hosting a party, and organizing a party in the way in which you want the party to be. So this is kind of my almost, if you like, epistemological position, and is rooted in the continued questioning of the nature of knowledge. Who is the knower and whose knowledge counts? So I want to be the one who is organizing the party. I want to be the one, together with others, who can create opportunities for organizing party, be visible, and be the voice of those living with HIV, especially when voices are not heard and not understood. It's a bit like imposing one language, and I'm making references to the fact that English is not my first language. So English is the language that everyone speaks, but it's not the language where necessarily we can communicate best. And that's the same when we try to understand what involvement means to many other communities. I think that as a way of concluding my brief talk today, I also want to say that it is my opinion that most people living with HIV do not have the wish or the desire to be involved. This is almost a must, it's a necessity. And I refer here to my personal experience. I would rather get on with my personal life if all my needs were met. So I'm kind of reacting to the current experience of being invisible and voiceless. I can only be acknowledged when and if I am perceived as a victim, because current service provisions for women living with HIV are still very much trapped in a sort of model of delivery, which is a women recipient of a kind of standardized model of care. A model which, I have to say, reflects at best of the times the approach which I normally define as other woman and steer approach, which is not an approach that is always welcome, or at least not welcome by me as a woman. And in a way, my involvement, and I hope the involvement of so many other communities, means that we can be outraged at the way in which, and now I'm referring to myself, my invisibility is constantly validated by the paradox that because I'm able to speak for myself sometimes, I can be invisible until and when it is needed. So referring specifically to women living with HIV, and again, I want to stress that there is not just one category of women living with HIV. What I want to say as a way of finally concluding, I don't want services for women living with HIV to replicate clusters of disempowerment in society. I think I need to be involved in discussion about service delivery because I'm proposing a much more compassionate and informed understanding of positionality and social transformation when they relate to informed empowerment-oriented practices. So I'm mindful of the importance of social, historical, and political context when theorizing empowerment. And I think that is fundamental to map empowerment as a sort of cyclical rather than a linear process. Today, being involved is a must, it's not a wish. And I hope that fast-track cities could provide a sort of opportunity for involvement. Thank you.
Thank you so much for that, Nicoletta. We have actually reached our question and answer session. I can see Bertrand has a question for Nicoletta straight away. Let me just stop sharing, and Bertrand, I'll let you ask away.
So it's not actually a question, sorry. It's more adding to what Nicoletta has just said, because it reminded me of three very different examples that I've lived through, and that to me are examples that we as individuals and as people working for organizations should always sort of re-question the way we look at things and the way we do make sure that people actually get involved. And I'm not saying that I'm doing that any better than anyone else, but in my previous job, I was director of a French NGO called SIDAction. That works on HIV, obviously. And two examples I have from that experience. The first one is that at one stage I hired a guy as an accountant, basically, in the organization. And the person I hired had spent 18 years in jail in France. And you know, if you spend 18 years in jail, you haven't stolen an orange. And he didn't know anything about the job he was supposed to do at SIDAction, but he knew everything about HIV in prisons in France, basically, and the lack of access to any kind of service related to HIV or HCV or TB or STIs in prisons in France. So anyway, we did hire him. He became very involved in the organization. He ended up being the finance director of the organization, which meant that he had the key to the safe. And at one stage, I had some of his colleagues, some of his co-workers working in an HIV organization coming to me saying, do you realize you gave the key to the safe to someone who spent 18 years in jail? I said, yes, I do realize, but so what? What's the problem with that? And some people some staff members had an issue with someone with that experience having access to that kind of power, basically, within the organization. That's just an example for me that, you know, we need to be careful that, again, communities and involvement is cross-sectional, and we don't come to any organization, any kind of job, paid or volunteer, any kind of involvement that we have with only one experience. And we have to make sure every day that we do respect people for what they are, and we take people, any individual with the diversity of their background. Backgrounds, actually. The other example I have in the same organization, we hired a guy who was an ex-teacher to develop HIV prevention programs in schools. So he had been a teacher for like 15 years. He had to stop working as a teacher because he was living with HIV and he was quite sick at the time. He was the best person to advise us on how to implement HIV programs in school, because he knew how the school system works in France. And the first meetings we had with him and the Ministry of Education in France, at the end of the meeting, the people who were working for the Ministry of Education came to me, not to him, came to me saying, why did you hire someone sick to run prevention programs? Right? So, and that was 10 years ago. That was not in 1984, right? So everywhere we have to make an effort to make sure that people are involved, not only in our organization, but get the right involvement when they get to work in partnership with people we want to or have to partner with sometimes. And that's a daily challenge. And I cannot imagine, you know, the way he would have reacted if people had told him instead of me. But that was just so offensive, I couldn't believe it. But anyway, the third example related directly to Fast Track City is about Warsaw. I didn't have time earlier to talk about Warsaw, so I'll do it now. But we're trying to involve Warsaw as a fast track city. One reason being that the mayor of Warsaw signed the LGBT Charter 18 months ago in a country where the national government is trying to implement what they call LGBT-free zones, right? When I last visited, which was 1 year ago, and I visited the hospital, all the doctors working in the infectious diseases department in the public hospitals in Warsaw, except from one, all the other doctors said, well, you know, there are patients, they have to do as we tell them. And that was in 2019 again, not in 1984. So I'm sure you've all heard about all the issues regarding the LGBT communities in Poland. And of course, that's also a priority for us. But the global way that the medical community, that's a kind of community, the medical community looks at people living with HIV in Poland, including in the leading public hospitals, doesn't say that they're ready for a fair involvement of people living with HIV in the design of program that they should be part of. So again, that's just to say that, as you said, Nicoletta, we're faced with multiple challenges, but being faced with multiple challenges doesn't mean that we should prioritize one over the other ones. Voilà.
So Bertrand, I'm actually going to ask you to speak a little bit more because a question did come in specifically for you. If you have seen it, it is asking that you said there are many local group and community projects. How can Scottish groups access this information?
So that's another challenge for us that I'm personally deeply concerned with, that if you look at the community organizations and community programs developed in fast-track cities, they're not developed in English, right? You talk to organizations of sex workers, migrants, MSM, only in Paris, 90% of them don't speak English. Their programs are not designed in English. They would not be able to be part of that kind of summit today, just because they wouldn't understand what we're talking about, and they wouldn't be able to interact with us in English the way I try to do. So one of the main challenge for an organization like mine, which is a global organization, is that the way we usually do business is everything is in English, which means everything is accessible only to people who speak English, right? What we've started doing in the past 2 years is implementing national workshops in a number of countries in Europe in the national language. So we've had workshops in Italian, Portuguese, Spanish, French, German, and English. And next year we'll have one in Russian as well. The next issue is, how do we facilitate the fact that a program that's been developed and implemented by a community in Italy where no one speaks English can be shared with people who might need it in France or Germany or here in Scotland, without having to incur the huge costs of translation, which is basically what is stopping us at the moment. So in short, I don't have an answer, but we are very aware of the question, and that's definitely a priority for us. But at the moment, I don't have an answer. Apart from, you can get access on the Fast Track Cities website to everything that is available in English, but everything that is available in English, it's a small minority of everything that does get implemented. Sorry.
Thank you very much for answering to the best of your ability there. It is definitely something that building a resource network can be very challenging, and that's how to link in and make sure that there are appropriate translations and consistent information is something that we're all striving for all the time, but it is incredibly difficult, and it is, I think, a lot what Fast Track Cities is working towards, is having this knowledge there and available for everybody to access, as and when. We do have 2 more questions that have come in. One from the chat, which has said, thanks to all the panelists for the excellent presentations. Given the nature of geography and in some cases the large urban areas directly surrounding our cities, but not necessarily part of them, I'm wondering what your thoughts on involving people living with HIV who don't live in the main areas of Aberdeen, Dundee, Edinburgh or Glasgow in the Fast Track Cities work.
I'll take that one, Heather.
Yeah, Colin, that's a good one for you.
So although we're Fast Track City Aberdeen, our positive voice is our positive voice Grampian. So at the moment, we've been working with Aberdeen City's Health and Wellbeing Social Care Partnership, but we, at the last 2 or 3 meetings, we have mentioned that we need to get involved with Aberdeenshire and Mourie's Health and Social Care Partnership, and that's what we're going to do, so that we are not just Aberdeen, but the whole of Grampian, so that we get the rural areas around our cities. And I think that's what each of the other cities need to do, is to look at the counties rather than the cities, and work on it like that. So, for example, we say we're out there in Moray and Aberdeenshire as well as Aberdeen City. So if anyone wants to get involved with our positive voice, they just have to contact us. We're not limited to the city, and if you get involved with our positive voice, you can become involved in Fast Track Cities.
Thanks very much for that, Colin. I don't know if Bertrand, you have anything you'd like to add into that?
Just that I know it's very confusing, but fast track cities is not limited to cities. It was at the beginning, but as Colin said, in many instances, we're going beyond the borders of the city for obvious reasons. You know, I mean, there can be epidemiological reasons. It can be that, you know, looking at Paris, for example, people living in the suburbs of Paris get access to care and treatment within Paris and not in the cities where they live around Paris. So if we want to have an impact, we have to involve all the cities around Paris as well. Yeah, what Colin has described is just the best way to make sure that people who want to get involved or need to get involved are actually involved, even if the initiative is called Fast Track Cities. What we want to do is involve local organizations and local leaders.
Thank you very much for that. We are going to start rounding up now. I would just like to ask from everybody their key bit of information about involvement they would like for everybody involved in the session to take away. And I would like to start with Nicoletta.
I think for me, the key point would be to make sure that we involve disenfranchised communities. So as I was listening to what we just said, I kept thinking about what about those who are homeless? What about those who, you know, we keep saying we facilitate people who want to join us, whatever we do. But I think that there should be also ways in which we welcome the process of facilitating this. And there are some communities which are still feeling not very much welcomed. I'm thinking about those who are homeless, or I'm thinking about those who are migrants, for instance. So that would be my kind of way forward to think about involvement.
Thank you, Nicoletta. And to you, Colin?
Yeah, I think it's about involvement. Don't be scared to speak up. Be able to ask questions. Don't think no question's a stupid question. And if you can't get support from your clinic or your GP, there are organizations like Our Positive Voice that will listen. And we, I know people are concerned about stigma and being recognized. We have ways. You can phone us, you can email us, you can talk to us privately. So there is a support out there if you know how to find it. And we're always looking for anyone that wants to get involved and help stamp the pavements and get the message out about you equals you.
Thank you, Colin. And the last point there from Bertrand.
So very quickly, I totally agree with Nicoletta and Colin. We need everyone involved in the process and at every step of the process if we want to have a real impact for people who need it. And you're the ones to do it, not me. But I always used to say that I was an expert at stupid questions, and then my ex-boss used to say to me, "There are no stupid questions, there are only stupid answers." So, as you said, every question is fine, and we should put ourselves in a position to be able to hear everything that people have to say.
Thank you very much, Bertrand, and thank you to all of our panelists and everybody that is here attending with us today. I hope you have found some useful information that you can take away that encourages you to think about involvement in your work and think about how you can incorporate involvement better, particularly for the voices that are less heard. But from us here today, we will say goodbye and thank you to everybody.
Thanks, bye.
Bye.